Juliana Chan. Professor Juliana Chan is a clinician scientist graduated from the Liverpool University, UK, with accreditations in endocrinology and clinical pharmacology after receiving a period of training in psychiatry. This is the most interesting part of her CV, which I love, that she also knows how to deal with the psychology of the patient. Over the years, she has organized many conferences, seminars, and workshops. She is currently a member of the steering committee in the Hong Kong government for control and prevention of non-communicable diseases and a Hong Kong government-funded theme-based research involving diabetes, and she takes personalized care of patients. So over to Dr. Juliana Chan for her first talk. A very warm welcome, Dr. Juliana, and the
Dr. Mina.
stage is all yours.
Thank you, Dr. Mina, for inviting me and for the introduction. So let me just share my slides. Can you see my slide?
No, not.
Okay, let me just try again. Okay, here we are. Share screen. Okay, share. So can you see my slide now?
Yes, we can.
Okay, thank you. So firstly, I would like to thank the organizing committee, particularly Dr. Sabu for inviting me to give this talk. So I thought I would take this opportunity to really share with you the Lancet Commission report on diabetes entitled Using Data to Transform People's Life and also Diabetes Care, which was really just published online in November, and is now actually full printed form in the January issue of the Lancet. Okay, let me just see. So we launched this report on the World Diabetes Day, the 14th of November, and you can download the entire report together with the editorial, the commentaries, and also a video, as well as this whole slide set actually from the Lancet website. So this really represents a 4-year project by 44 global experts and researchers in epidemiology, public health, clinical care, and health economics from 5 continents to propose action plans in order to reduce the burden of diabetes and NCD. In this particular, over these 4 years, we have done really extensive data mining, to actually curate, to review the literature, and also to synthesize new evidence, and most importantly, really propose actions, and also in order to, at both a macro environment level as well as a micro environment level, in order to improve care. So here you could see that actually, despite the availability of insulin, for nearly 100 years, and we're going to celebrate the centenary insulin next year, there is still considerable variation in type 1 diabetes related mortality, as high as, for example, 40 per 1,000 person years in areas like Ghana and also Middle Europe and Central Asia, as well as to 0, for example, in high-income carriers like India. It is this epidemiology, this variation, that indicate there is tremendous opportunities for improvement. Even in high income, however, we've already heard from Dr. Mazzi that even in type 1 diabetes, despite all the technologies, we still have a lot of improvement to make. This is really the Pittsburgh Diabetes Register established in USA, and you could see that over time, these are the years of diagnosis of these individuals, and that's really over time there is really the mortality rate or the diabetes-related complications have not really changed over these periods of time. So people diagnosed in 1950 as compared to people diagnosed in 1975, although there's a seemingly reduced incidence of complications. Actually, statistically, they were not different. They were very similar. Of course, within this, there's actually considerable variations with a lot of social disparity, particularly in people who are coming from the minor ethnic group, as well as people from, the low-income groups, which obviously give the highest incidence of complications. However, we use modeling to show that actually we can make a difference if we can actually improve care. So if we use, we now know even in high-income countries, the standard mortality rates of people with type 1 diabetes is 2.5 compared to those without diabetes. Even these many of these people in the high income countries are receiving comprehensive care. So in upper middle income countries, and for those people who are receiving intermediate care, the SMR is 4.9. However, this increased further to about 13 to 33 standard mortality rates compared to those without diabetes. And note that these are all very young people, depending where they live, whether it's lower middle income countries most of these people are really just receiving intermediate care or even very minimal care. So in 2017, 1.61 million people with type 1 diabetes aged less than 25 years were diagnosed before the age of 20. And during this period of time, 14,000 young individuals with type 1 diabetes died. We estimated that 84% of these deaths, could have been prevented if all nations implemented guideline-based intermediate care, for which we mean basal bolus human insulin regimen, tools for self-monitoring blood glucose, education for self-management, and regular A1C monitoring and complication screening. And if we implement comprehensive care, which include CGM, for example, you could see that actually the rate of mortality can be tremendously reduced. We also, over the last 30 years, we've really done a lot of research, and there is now evidence-based strategy in type 1 diabetes, including, the reduction of A1C, the blood pressure, the LDL cholesterol. They can each individually or collectively reduce the risk of cardiovascular disease or cause death by 10 to 20% in people with type 2 diabetes. In particular, the use of statins and renin-angiotensin systems inhibitors can also prevent this cardiovascular renal event, by 20 to 40% in people with or without diabetes or high risk for having diabetes. SGLT2 inhibitors, the GLP-1 receptor agonists, they are game changers, and we know that they can independently reduce CV and renal events and death. Most importantly, to make this happen, we need to use data-driven, team-based integrated care through care reorganizations, and that has now been shown to reduce cardiovascular events by 20 to 60%. And in terms of prevention, if we can sustain weight reduction in obese subjects with type 2 diabetes who have diabetes for less than 6 years by 15 kilograms more, we can actually induce remission of type 2 diabetes for up to 2 years. Structured lifestyle modification, structured lifestyle intervention, and use of metformin can also each prevent or delay type 2 diabetes in individuals with impaired glucose tolerance. But the challenge is, how do we make this happen? We've heard that actually, despite all these technologies, we now have nearly 9 drugs, oral drugs and injectables. These are really large surveys. So we curated data for 1.9 million people with type 2 diabetes in cohorts with at least 5,000 individuals. And you could see that particularly in type 1 diabetes and young people with type 2 diabetes, really less than 50% of these people are at the goal of 7%, which is still 1% higher than a normal A1C. However, and this obviously contributes to the increasing incidence of complications and death related to diabetes. Once again, it is the variations that actually give us the hope that something can be done. Here you could see that in many high income areas, there is actually declining, the mortality rate of diabetes is actually declining in some of these countries where, for example, there are universal health coverage, there is better healthcare system, and that people are actually more informed. And so how do we actually translate this kind of benefit to the greater number of people in the low and middle countries, which actually account for 80% of the people with complications? 80% of people people with diabetes are actually living in low and middle income countries. Again, we performed extensive meta-analysis, and again, really simple things like reducing A1C by 0.9%, reducing 10 millimeters mercury of blood pressure, and the benefit is more obvious in those with high blood pressure, and also than those with lower blood pressure, and also the reduction of 1 millimoles of LDL cholesterol. We could really reduce, both all-cause death, cardiovascular death, ischemic heart disease, and stroke, anywhere between 10 to 30%. And again, using modeling, we estimated that in these 10 top lower middle income countries, including India, which account for 50% of the diabetes burden in the world, that actually in 2017, you could see that we can expect 3 million of deaths due to diabetes, and 1/3 of this is actually due to cardiovascular disease, either due to stroke or myocardial infarction. However, by ensuring that these people are having access to statins, okay, to reduce the cholesterol, and also blood pressure drugs to reduce systolic blood pressure, we can actually reduce nearly 1 million deaths just by ensuring that these drugs are given to these individuals. However, in this report, we also pointed out that there is actually considerable variations in terms of the prices of these life-saving drugs, even though many of these drugs are now generic. And of course, the high price of a lot of the insulin has always been in the headline, even in high-income countries. And so this is really where the government has to do something to improve the macro environment to ensure that these life-saving drugs are actually affordable and accessible to all people with diabetes. At the same time, we also, while we have now sort of data suggesting diabetes are highly treatable, there are now also emerging challenges. And that is particularly the rising incidence of young onset diabetes, which will result in premature death and comorbidities after 20 or 30 years of uncontrolled or unmanaged diabetes. And this is really, again, showing that because of the lower risk of death among young people without diabetes, the standard mortality rate of people with diabetes is particularly stark in people who are in the younger age group. And more importantly, these young people are actually at risk of multiple morbidities, and particularly, this is really a study really showing the accrual of hospitalizations during a lifetime in people with young onset diabetes, and that as time goes on, during the 30 years, these people would have spent more than 100 days in the hospital. And with with mental illness being a very important cause of hospitalization during the early course of disease, and then later on replaced by cardiovascular and renal diseases. And here, infections is also a very important cause of hospitalization in these young people. The important thing is, again, we've heard repeatedly from previous lectures that we are dealing with behavior. And in order to change behavior, education and also motivations are important. And to do that, relying on doctors alone is difficult. And here, this is a meta-analysis showing that by really shifting tasks, in other words, using other non-physician staff to relate to engage the individuals with diabetes, and also to maintain the provider and patient communications. Focusing on promoting self-management is associated with reduction in A1C, blood pressure, and LDL cholesterol, and these are substantial reduction in risk factors. By these quality improvement program on top of whatever is happening to these individuals. So in this Lancet report, we highlight the importance of using preferably diabetes centers, diabetes teams, and also to implement plans and establish registers in order to integrate care delivery, in order to also educate not just the patients, but also the professionals. And most importantly, is to collect data systematically to drive actions. And this is really showing that specialist diabetes centers really serve multiple purposes. Here, we have diabetes mini teams and multidisciplinary diabetes centers work collectively to provide different services, particularly structured assessment, diabetes register for risk stratification and care triage. Importantly, to use that data to provide feedback and to empower and to encore individuals. And in order to provide continuing care, to promote self-management and to provide ongoing social support and lifestyle changes. And if we can link these registers to population and hospitalization statistics, we'll be able to understand more about the causes and consequences of diabetes and to evaluate the impact of these programs. In these reports, we also highlight, a data set, to establish diabetes register, which need to be collected at baseline and maybe every 2 years. And this will ensure quality assurance and also to deliver these multiple purposes. And imagine a person diagnosed with diabetes at the age of 40. All we need is really 20 assessments throughout his life journey, which would really make a huge difference to this outcome. So again, using modeling, we were able to demonstrate that, for example, here, using the data in China, and assuming that 50% of people are diagnosed, and that among people who are diagnosed, 70% are treated for 3 years in order to reduce the various sorts of A1C, LDL cholesterol, and also blood pressure. And by actually reducing all these risk factors on top of the integrated care, again, we can actually reduce nearly 1 million cardiovascular events. And this is really showing that, if we start because we know most of these complications are 3 to 9 times more expensive than those without complications, the sort of money that we can save talking about in terms of billions. And indeed, there are examples just really using Hong Kong, which is a small city, but a very reasonably good system, and where we can collect data very systematically. We were able to show that this territory-wide risk assessment management program have really contributed towards the reduction, 50 to 70% risk reduction in terms of death rates, in all age groups, particularly overall. But the evidence is actually less in young people, which is another unmet need. But by and large, you could see that actually there is significant reduction in terms of all-cause death, in terms of diabetes complications, and in terms of acute complications such as tuberculosis. Of course, diabetes is not just a personal problem, it is also a societal problem. So in this report, we really give a very macro view so that there is something for everybody, and highlighting that really we are actually facing demographic and also ecosystem changes, and there are a lot of changes in terms of lifestyle which contribute to the development of these risk factors, which culminate to cause these multiple comorbidities and ultimately premature death. At every level, we will need integrated and cohesive strategies in order to deliver context-relevant policies, to promote community health literacy and patient empowerment, strengthen the primary care, which is well linked to the secondary and tertiary care, in order to reduce all these the morbidities and mortalities. And so what we are proposing are absolutely in line with what are being proposed by the United Nations in terms of the SDG, the Sustainable Developmental Goals, the WHO, in terms of the professional guidelines, in terms of the framework for control of NCD, and also the professional guidelines in terms of how to deliver care on an individual basis. So at the individual level, integrate care with teams. Community level, lifestyle changes, use of metformin, health policies such as sugar tests, and reducing trans fats, of course, universal health coverage, and at societal level, really protecting the environment, reducing social disparity, and improving health literacy, general education. But more importantly, diabetes is a lifelong disease. And here, we're really talking about, the transgenerational nature of diabetes, and that we really have to improve both the maternal and also childhood health in order to reduce childhood obesity, improve maternal health, in order to stop the cycle of the vicious cycle of diabetes begetting diabetes. Now we highlighted a very important concept, and that is in clinical care, very often we do observational studies, through the epidemiology, we understand the risk factors, the effect size, and then we actually do intervention, and very often we do pilot studies, feasibility studies, then we do definitive randomized trials, and then we synthesize the evidence using meta-analysis, and this will then actually drive the policy and form the basis of professional guidelines. However, in the more macro environment, particularly when we talk about population policy, and we will actually need a different approach, and that is we need the political will, actually based on available evidence, to actually implement the policies. But most importantly is to continually gather data in order to evaluate the impact of these policies in a naturalistic environment. And by so doing, we start actually gathering the synthesis, gathering the evidence, and then to actually inform decisions. So these are really two approaches, how we actually deliver evidence-based practice and also practice-based evaluation. So again, in this comprehensive report, we use modeling again, based on available evidence, to really estimate, for example, in a population, assuming how many people have diabetes, how many people are at risk of developing diabetes, and how many people are at risk of actually developing pre-diabetes, because pre-diabetes and diabetes can all convert to cardiovascular diseases. And if we can actually implement in societal, population and community-based strategies by promoting public health, early detection and intervention, by strengthening both the primary healthcare system, then we can estimate that after 10 years, we can actually prevent 22,000 diabetes events and also 17,000 cardiovascular events. And for 1.3 billion people in China, after 20 years, we could have saved 44 million cases of diabetes and 67 million of cases of cardiovascular diseases. So, so I think it is important, again, to note that at least from, I understand the audience are mainly clinicians, that there is really consensus both at the IDF as well as, for example, KDIGO, and particularly in this Lancet report, that because of the silent and continuous progressive nature of diabetes, there is really a need to register these individuals systematically, to assess the risk, to stratify the risk, and to review these risk factors in order to control them, and relay these risk factors back to the patients and the care providers to reinforce compliance, and also for early intervention, and to recall to avoid default. Really, our goals are simple: to promote self-management, to treat to multiple targets, and with ongoing medical and psychosocial support. And these databases can not only influence decision at a personalized level, a bit like the CGM, at the doctor's level, other healthcare professional, but also at the system level. Most importantly, it's the payers, so that they understand the value of preventive care in order to save life and money. So with that, I would like to finish and really encourage you to see this video. These are, again, as I said, you can download the link from the Lancet, website, and there is a Lancet webinar where we have a 1-hour discussion where we have the commissioners summarizing some of the key messages. We have Dr. Richard Horton, the editor of Lancet, that invite us to do this analysis, his view about this problem. We have stories actually from patients, and including patients from India, really telling their perspective, and this message really come through, and that is education. Only if they know, they would have changed, they would have improved their care, and they would have been more compliant with the treatment in order not to get unnecessary heart attack, etc. And also people from, clinicians from developing world saying how much they need help from the government and also from the payers to make that happen. And so I hope, my brief discussion presentation will motivate, and also hopefully some of you to join this global movement in order to use data to translate, to use data to close the gaps. And I think one of the important things is really we have to close the professional knowledge gaps, particularly like these kind of meetings. And I think the one thing out of this COVID-19 is now these educational forum can reach out to so many people. But of course, importantly, we should make that knowledge available and into actions and to help patients. Thank you.